Guys, welcome. I'm Olivia. Most of you know me. I'm the second-year PEM Fellow. I'm going to speak about pediatric ataxia and myelopathies this morning. I obviously have no financial disclosures. My objectives today are to discuss acute ataxia etiologies and management, and discuss and differentiate pediatric myelopathies or myelitis, and then kind of board review cases intermittently throughout the lecture. Does anyone want to read the first case? Go ahead, Adam.
7-year-old previously healthy boy is brought to the ED for altered mental status and ataxia. He has been jumping on the trampoline at home. He's doing flips with older brother. When he went into his house, mom noted him to be confused, stumbling, and having difficulty walking. He's normothermic, borderline tachycardic, respiratory rate is a little bit up, but okay. Normal blood pressure, normal GCS, but a little bit diminished. On exam, he's noted to have ataxic gait, falls to his left side. ANO times 1, just name. No C-spine tenderness, no obvious bruising, swelling, obvious deformity to the head, back, neck, or torso. CNs are intact with symmetric strength and 2+ reflexes. Which set of management options should be obtained first?
Okay, you guys can put in the chat your answers, and then people in person can just raise their hand. So A, B, C, D, or E. Okay, no one raised their hand, so let's start over. So for A, okay, a few. B, C, okay, D, and E. Okay. All right, so the answer is A. So you'd want to get a CT angio of the head and neck. So this patient has an acute intracranial process despite a seemingly minor trauma, right? So besides evaluating for an intracranial bleed, like an epidural, subdural hemorrhage, we really should consider injury to the carotid or vertebral arteries. With this presentation, as Adam mentioned, flipping on a trampoline pad, right? So presentation of altered mental status in this kid and trampoline use, assumingly unwitnessed injury. With trampoline use, you can have hyperextension and hyperflexion injuries, resulting in intimal tear to the vessel wall with subsequent dissection and or thrombus formation. So cerebral infarcts from vertebral artery dissection can present with a range of symptoms, obviously, but dysarthria, headache, neck pain, vertigo, nausea, vomiting, hemiparesis, ataxia, and or seizures. So C-spine films and non-con CT alone would potentially miss a vertebral artery injury. So this is just an introduction into acute ataxia. This is a nice lengthy algorithm approach as to how to think about acute ataxia in kids. So when thinking about how to approach acute ataxia in kids, we can first consider whether there's a history of head or neck trauma, which in this first case, there was likely an unwitnessed injury on the trampoline. So we set for neuroinjury with concern for possible vertebral basilar artery dissection, cerebellar contusion, or some other traumatic injury leading to ataxia. Versus no trauma present, then we consider the presence of focal neuro findings, fever, toxin exposure that kind of make us consider other acute conditions such as infection, post-infectious causes, malignancy, or ingestion. So going down the right side of the algorithm, that's kind of what we'll focus more so on today, which are going to be kind of your infectious and post-infectious causes, malignancy, and ingestion. Okay, so how do we define ataxia? We have a disturbance in coordination. Typically, these kids will present with an unsteady gait or refusal to walk, or refusal to bear weight. They typically have a wide-based gait as opposed to a narrow-based gait. And then midline lesions can also cause truncal ataxia with swaying with being upright, or titubations with small rhythmic movements of the head and neck. And ataxia is a disturbance in coordination, typically in some form from the cerebellum or the posterior fossa region. So life-threatening causes of acute ataxia are typically uncommon, but classified as within less than 7 days, and generally include your intracranial hemorrhages, stroke, tumor, infection. So as far as bleeding, so you want to consider vertebral or basilar artery disease or stroke. So kids that have history of sickle cell, nephrotic syndrome, lupus, or other hypercoagulable states. And then other sort of hemorrhage into the cerebellum or posterior fossa. And as I mentioned, the vertebral basilar artery dissection secondary to neck trauma or injuries can cause stroke, particularly hemorrhagic, such as the trampoline trauma. A little bit less common. Something to really consider in kids are posterior fossa tumors. So kids technically are pediatric CNS tumors. The more common ones are infratentorial as opposed to the supratentorial. So your infratentorial tumors are going to be encompassing more of the posterior fossa and brainstem. Versus supratentorial is more so the cerebral aspect of the brain. So about 60% of pediatric CNS tumors include or are kind of found in the brainstem or cerebellum. And you want to think about the limited amount of space in that area and the potential for increased ICP, hydrocephalus, and cord compression. And then there's a lot of vital brainstem nuclei in that region. And so when you think about the different cranial nerves that are found in that region, it kind of makes sense as far as what kind of presentation you'll see. So the brainstem nuclei, I'm not going to go too much into this, but if you think about cranial nerves, 3, 4, 5, you have your oculomotor, so you'll have vision disturbances, your trigeminal, sensory and motor, 6, 7, so facial, 10 and 12. So posterior fossa tumors, which encompass the cerebellum, so thinking about your balance center and brainstem, they typically present with dysarthria, ataxia, visual disturbances, and then behavior problems. So some of the most common posterior fossa tumors are going to be your medulloblastoma, which are kind of the most common, and pilocytic astrocytomas. So medulloblastomas are typically found in the cerebellum or the roof of the fourth ventricle, and those are really associated with drop nets. Versus your pilocytic astrocytomas are going to be in the cerebellum and brainstem. They're kind of the second most common posterior fossa tumors, and they can have a similar appearance to the hemangiomablastomas, but can be differentiated by a cyst wall, and they're associated usually with NF1. The gliomas are typically found in the brainstem, also associated with NF1. But just as far as, oh, sorry. So the gliomas are associated with NF1, as well as pilocytic astrocytomas. But the medulloblastomas are the ones that are going to be the most common posterior fossa tumors in childhood, and those are the ones that are going to be associated with your drop nets. And so when thinking about acute ataxia and tumors, you really want to consider those kinds of tumors. So we had I had a child in residency who presented initially 7-year-old with gastro-like symptoms for a week, who was assumed to have acute cerebellar ataxia. The child had a week of gastro-like symptoms, so vomiting and diarrhea, developed ataxia about a week and a half later or so, but the ataxia worsened as the vomiting and diarrhea kind of improved. So at first we were thinking that this child had the kind of benign condition of acute cerebellar ataxia, but as we noticed that the ataxia kind of worsened, we ended up sending him for imaging and found a pretty significant medulloblastoma in the posterior fossa with significant drop mets or leptomeningeal enhancement. So these kids can present with progressive ataxia, AM headaches, nausea, vomiting, papilledema, and some of the other cranial nerve palsies that I mentioned. Okay, so next question, anyone want to read? Sure.
On denied any people or physical exam, temperature 37.8, heart rate is 120, BP 100 over 60, oxygen saturation of 1%. She's active with the renal nerves are intact, management, reflexes. However, you know, movement, multi-directional bilateral eye movement that lasts several seconds, and force tremors and occasional jerky movements. She also has a wide base unsteady gait. The remainder of her exam MRI of the brain, B MRI of the brain, spine, C CSF analysis and genetic testing, D CT scan of the chest, abdomen, and pelvis.
All right, I'll give you guys a second to think about it. Okay, so anyone for A?
They're also talking about these abnormal jerking movements of both legs.
Mhm.
They're going to point you to a particular syndrome.
Yeah, don't give too much away, but
Yeah,
yes.
exactly. And so then you think about this particular syndrome and what it's associated with.
Exactly.
This is a core question that comes up a lot.
Thanks, Rosie. Okay. All right, so anyone for A? Okay, B? Sure, C? Cool. D? Okay, or E?
Y'all know what this is?
Okay. Okay, all right, I'm gonna talk about it. So, all right, so the answer is D, CT scan of the chest, abdomen, and pelvis. All right, so as Rosie was pointing out, so we're talking about neuroblastoma, opsoclonus myoclonus. So neuroblastoma, neoplasm or malignancy of the sympathetic system derived from the neurocrest cells. So 90% of these tumors are found in the adrenal medulla or sympathetic chain. They're really challenging to detect because they can often be super small. These tumors have an increased HVA and VMA in the urine, which are basically catecholamines that are secreted by these catecholamine secreting tumors. These tumors tend to have a better prognosis with diagnosis at a younger age. About 70% of kids survive greater than 5 years after the neuroblastoma diagnosis. So acute ataxia in association with opsoclonus myoclonus or OMS. It can be the presenting manifestation of occult neuroblastoma. So OMS, what is it? So dancing eyes, dancing feet is kind of the generic name for it. It's a paraneoplastic autoimmune phenomenon resulting from neuroblastomas. And so whenever we see this, as you can see in the image below, kind of these dancing eyes, dancing feet in a kid, less than a year, less than 2 years old or so, we really want to do an aggressive search for malignancy, particularly CT or MRI of the chest, abdomen, pelvis. So OMS is triggered by immune response to neuroblastoma, cross-reactivity with the healthy brain, particularly the cerebellum, versus MRI of the brain or MRA of the brain would be indicated for suspicion of a brain mass, vasculitis or vascular anomaly, which would not be associated with OMS. So that's why that choice is wrong. And CSF would be normal in this case, not really helpful. And then heavy metals like lead and zinc is what the answer was alluded to. Can cause neuropathies, but not the findings on this exam. So opsoclonus basically involves uncontrolled, frequent, really high amplitude multi-directional conjugate eye movements in all directions, where myoclonus consists of body jerks, truncal and limb ataxia, along with developmental regression, sleep disturbances, irritability. And typically, so about 80% of the time, a neuroblastoma or ganglioneuroblastom is often recognized, but not always present. And these kids can present as early as 6 months old, but the greatest incidence is usually 1 to 4 years old. So OMS can have really short and long-term consequences, neurological and developmental effects. The neuroblastoma tumors often regress with immune response, but the same immune responses can also adversely affect the brain, resulting in cognitive, behavioral, motor deficits. And so treatment would be immunosuppressive, steroids, IVIG, rituximab, ACTH. Basically, the goal of the treatment is to reduce long-term neurologic effects, the developmental, cognitive, and behavioral ones that I mentioned. Okay, so other sort of acute ataxia findings. So infection, you want to think about abscess. So any sort of infection spreading from acute otitis or the mastoid, brainstem encephalitis. These kids typically present with fever, cranial nerve abnormalities, altered mental status, and seizures. You would see EEG changes. The bugs typically found with these are Listeria, Lyme Borrelia burgdorferi, or Lyme disease bug, EBV, herpes, and then reflexes are preserved, and then ADEM, which I'll talk about. So when thinking about infection, you want to think about abscess. So abscess is typically secondary to otic infection. So otitis media or mastoiditis typically spread to the cerebellum or the temporal lobe. These bugs are usually your anaerobe strep and pseudomonas versus direct spread from the sinus. Typically affect the frontal lobe. But keep in mind that serious complications from otitis resulting in brain abscess are quite rare, which is still important to keep in mind. I usually pick about 4 to 7 years, and then the most common predisposing conditions are cyanotic congenital heart disease, so hematogenous spread from there, and direct spread from a contiguous site. So the middle ear, sinuses, teeth, poor dental hygiene, and then complication from dental procedures. Brain abscess uncommonly complicates bacterial meningitis or head trauma, usually with a significant delay from the time of injury. So bacterial culprits, you want to think, so for neonates, Citrobacter is kind of the main one, but you also want to think about Proteus and Enterobacter. And then for your kids older than a month old, strep and staph are the typical bugs. And then treatment for brain abscesses, particularly those associated with sinusitis, mastoiditis, otitis, and congenital heart disease. You want to start these kids on a 3rd generation cephalosporin, so ceftriaxone, and flagyl. So these antibiotics particularly penetrate the blood-brain barrier. So Clinda was initially thought to be an antibiotic of choice, but it doesn't penetrate the blood-brain barrier as well. So flagyl is a better choice. And then considering dexamethasone or steroids as well to limit the edema that can contribute to increased ICP. Blood cultures in these cases are not really helpful, only about positive in about 10% of the time. And then your classic CT with contrast shows that ring enhancing lesion, but that can lie behind the clinical presentation. Okay. Who wants to read the next question? Go ahead.
4-year-old pregnancy, healthy, vaccinated male presents DED, reported as progressive lethargy and behavior. Today he complained of headache and slept for most of the day. Mom noted mumbling speech while awake today, which is abnormal for him. 2 weeks ago, he was seen in the CED for URI infection. Well, yesterday he had a 3-minute afibrotic generalized seizure, and he was seen in the CED. His parents were reassured. On physical exam, he has a normal temperature, his heart rate is normal, normal respiratory rate, normal blood pressure, normal saturations, and slightly his GCS is 12.
Mhm.
Although I guess it's not trauma, so-
Yeah, it's not trauma, but it was included in the question.
He's limited cooperation with motor exam, but appears to be all extremities, refusing to stand or walk, and unintelligible words. Cranial nerve exam is incomplete due to lack of cooperation. Obtain a statin 6 week out contrast, which is no longer further diagnosis testing. A, IV Centraxone, B, Ebrad, C, IV steroids, D, plasma exchange.
Okay, so I'll give you guys a second. Okay, so anyone for A? B? C? D? Or E? So the answer is C, IV steroids. So let's talk about ADEM. Okay, so acute disseminated encephalomyelitis, also known as post-infectious encephalomyelitis. So the exact etiology is not entirely known, right? But ADEM is thought to be an autoimmune disorder triggered by an environmental factor like viral illness, typically in genetically predisposed patients, but not always. ADEM is post-infectious, so symptoms typically occur about 2 weeks after the fever viral syndrome, typically URI, so Coxsackie, influenza, EBV, just to name a few. And then literature shows no association with post-childhood vaccination. Average onset of ages 3 to 7 years old, relatively uncommon, but I've seen actually a few cases in residency. So basically the EBV virus nuclear antigen shares an epitope with the major protein of the myelin sheath. Antiviral antibodies or cell-mediated response to the pathogen cross-react with the myelin autoantigens, resulting in ADEM is the thought process behind it. So it's inflammatory and demyelinating process where multiple foci of the demyelination develop within the brain and spinal cord, as you can see the image on the right. Encephalopathy is a requirement for ADEM, and that's kind of what differentiates it with from a little bit more serious, similar conditions. So either behavioral changes, confusion, excess irritability, alterations in mental status or consciousness, lethargy. It's unexplained by fever, systemic illness, or postictal symptoms is a requirement, and usually develops rapidly in association with multifocal neurological deficits. So your cranial nerve palsies, seizures, weakness, ataxia, hemiparesis, sensory deficits, vision changes. Less commonly aphasia and movement disorders, but also can be seen. And then can also present with systemic symptoms like fever, headache, and meningismus. So altered mental status and the fulminant onset of multifocal neurologic deficits is what kind of, like I said, distinguishes ADEM from more benign etiologies like acute cerebellar ataxia. The more severe phase of ADEM typically lasts from 2 to 4 weeks. Oh.
Quick question. Is there something specific about this patient's presentation that should include this in and specifically, or was it that the patient had an infection or?
Yeah, so that's a great question. So here, as you can see, like the third line down, 2 weeks ago, he had he basically had 2 weeks of a viral illness that post-virally, he ended up having this kind of altered mental status and encephalopathy. So progressive lethargy and behavioral changes, mumbling speech. So he was encephalopathic sort of 2 weeks post his viral illness.
Yeah, you're supposed to have like encephalopathy, right? So you have a 4-year-old who should be able to give you full sentences and tell you the story, and all of a sudden
He's mumbling.
That's not normal.
Yeah.
And the fact that he's having a seizure when he's never had seizure prior, that should also tip you off that there's something going on in the brain. Like usually when we think behavior changes, seizure, and like different altered mental status, right? So you're thinking NMDA encephalitis,
Does that make sense?
Like, I guess it's kind of a broad, non-specific, like, picture.
Mhm.
That I feel like, I don't know that I would, I guess if there's something specific about like ADEM versus like viral influenza or something like.
So I think the key is exactly as Liv's saying, is that the preceding viral infection. So if you were thinking this was acute encephalitis, you would assume that they would have some acute infectious process, right? Usually encephalitides is not usually post-viral. You have acute HSV encephalitis or meningitis, or you have an acute infection that's causing your acute alternate status. In this story, as soon as you hear 2 weeks ago he had a preceding URI, that's the key that is here. ADEM is a post-infectious autoimmune condition that's only treated with immunosuppressive, aka high dose IV steroids.
Exactly. So
So that's not uncommon for sure. Sorry, say it again, that's something.
How do I know it's not a new virus and stuff like that?
Because he doesn't have a fever, it's not a viral seizure. I mean,
That's a more question, right? So the thing you have to tease out of here is in real life, you may not know. In real life, you'd be like, this is encephalitis, this is meningitis, but before, the way that you're gonna tease this out is you'd be like, all right, you had an infection 2 weeks ago, you're not fibro now, and you had a seizure yesterday. My best choice would be, say again?
How do I get away from having this kid?
That's not one of your choices, right? So for this
Yeah.
board, like real life, you may end up tapping the kid.
Right.
You're gonna get a head TT because they are well, and then you can probably like be tapping it. That's okay, but for the board. But in real life, you may not be.
right, and all of these
Exactly.
choices are treatments, right? None of them are diagnostic tests. So, I mean, ultimately what it comes down to is if even if you have a preexisting history of febrile seizure, they come in, they have a viral URI, they're not febrile. If they have a seizure, it is not a febrile seizure. You have to have it. And like again, you can have some encephalopathy, but the fact that he has a seizure, he has altered mental status, it means that there's some sort of encephalitis, and it should make you think about it.
Exactly. That pretty much covers it. Like it's not an acute phase of this encephalopathy with these viral symptoms. The key is that it's post-infectious, it's post-viral. Like Dr. Silverberg said, in real life, you could potentially tap the kid, but for boards, these are kind of treatments as opposed to diagnostic modalities. So thinking about post-viral plus this encephalopathic picture is what kind of clues you into ADEM as opposed to viral encephalitis.
What?
You have to, but you have to.
Yeah. So because it's a autoimmune condition into the brain, right? So there's going to be antibodies in the cerebrospinal
Might
fluid.
be elevated points. Might not necessarily see an elevated point.
Maybe not. Yes. Yes or no? It's not a definitive yes.
You're gonna tap these kids regardless.
Yeah, you're gonna
They're
tap
all
them.
status with coming in, but ultimately, like, you have to think about the highest thing on your differential and the thing that makes the most sense. You're probably gonna give antibiotics, but you should definitely also think about giving IV steroids, because this points to a post-infectious process.
Exactly.
I think it's like, one of the things you were like, in a real life setting, I would probably give like baby like I
So
would.
I think you're completely correct. I think that in the real life, that's the problem with the board question, right? The board question is trying to point you to a very specific answer. And if you were to look at the explanations, they have a specific reason why you don't need each individual answer, right? So he had a 3-minute generalized seizure, right, that stopped in the past, right? He's not acutely seizing, so IV Keppra is unnecessary for him at this exact moment. IV ceftriaxone is also probably unnecessary at this exact moment because he's not febrile. Then plasma exchange, that's definitely not necessary in this situation.
Mhm.
And then IV acyclovir is probably also unnecessary. You can't say that this is a HSV encephalitis or meningitis.
You guys have played this game before, it's the same exact.
I feel like the reason for the board is to make you a good doctor, take care of the kid. If I was seeing this kid, I don't think I would give him steroids right away. I don't think I would do.
Well, this is the
Especially
point of us
for
doing some more questions for teaching, right?
Yeah, I teach you to be a good doctor to work with.
Right, but this is also it's a very specific kind of scenario for ADEM. So this is something that we're seeing. Yeah, exactly.
a matter of bringing awareness.
Yeah, I
To
think
this
this
condition.
trial is something not
Exactly.
And I would back up Dr. Chow, but I've seen a lot of these residencies.
So yeah, same.
And usually Dr. Silverberg can do exactly what you're saying. They come in altered with some local deficit, so they get tapped, they get antibiotics.
And
they get
steroids.
And then after talking neurology, they get an MRI, and the MRI shows scattered lesions. They go, oh, and they put the kid on high dose steroids. Kid's in the NICU for a couple days, couple weeks, gets totally better, goes to PT, OT, goes home, and is doing totally fine a year later.
That's fine, that makes more sense, but I'm saying when I'm seeing patients, I don't think I would do it.
Right, but I think as we're saying, this board question is to just raise awareness to this common pediatric presentation. But I think the key is to go through each answer and to find why you would give each one specifically. And when I hear previous viral illness and new focal encephalitis, I'm immediately thinking ADEM because I know it's pretty common in kids.
Okay, great. Thanks, guys. All right. Okay, so I think we've talked about ADEM ad nauseum at this point. But the other kind of key thing, so as I forget if it was Mo or Dr. Zorberg who mentioned, but CSF actually can show pleocytosis. So obviously would tap the kid potentially an elevated protein, but normal glucose, but also may be normal, so not as reliable. Treatment, first line therapy is high dose steroids, methylpred. IVIG is often used as well as an alternative, but limited data to support effectiveness of Plex, particularly first line, but plasma exchange can be used in kind of more fulminant or refractory conditions. And then about 60 to 90% of kids with ADEM do achieve full recovery within 6 weeks with no lasting neuro deficits. And this is just a recent retrospective study that evaluated variation in treatment and outcomes of patients with ADEM and found quite a bit of variation in treatment and ICU admissions. But as I mentioned, kind of first line therapy is high dose steroids and then Plex for kind of more fulminant conditions. So some more common conditions of acute ataxia. So acute cerebellar ataxia and Guillain-Barré as well. So those are kind of the most common, especially the acute cerebellar ataxia. And then toxic exposures, labyrinthitis, a little less common, and trauma. So the most common cause of pediatric acute ataxia cases, typically post-infectious again in kids less than 6 years old. Again, cross-reactivity of antibodies to epitopes in the cerebellum usually evolves up to 3 weeks after the viral symptoms have subsided and usually resolves within about 2 weeks. The onset of ataxia can be quite rapid with kids kind of awakening in the morning, complaining of inability to walk or just flat out refusing to walk. In cases with prodromal illness, the ataxia typically follows within days to weeks. Gait disturbance is the primary symptom in most patients, but in other patients, cerebellar dysfunction can be limited to fine motor control problems or tremor. And then associated symptoms can be nystagmus, which is present in about half of cases reported, 50% of cases reported, and then slurred speech, vomiting, dysarthria, irritability. So for acute cerebellar ataxia, imaging is typically actually not indicated. It's generally a diagnosis of exclusion, but these would be some neuroimaging indications, so alteration of consciousness or mental status, asymmetric or focal weakness, like sort of an atypical disease course. So worsening ataxia, as the kid I mentioned that ended up having a medulloblastoma with initial GI symptoms, new and unremitting headache, and then concern for head or neck trauma. Versus acute cereballitis is a less common and more severe form of acute cerebellar ataxia, typically post-infectious as well. You'll have an acute onset of ataxia, nystagmus, dysmetria, so signs of cerebellar dysfunction, accompanied by fever, nausea, headache, altered mental status. The common bugs are kind of similar to those found in acute cerebellar ataxia, so Coxsackie, echovirus, enterovirus, EBV. Altered mental status and cerebellar abnormalities on the brain MRI, typically diffuse bilateral or bihemispheric changes. Treatment is similar to ADEM and typically consists of high-dose steroids. Guillain-Barré, which we're quite familiar with, so also post-infectious, typically respiratory or GI prodromal symptoms. The most common cause of acute flaccid paralysis in healthy kids, increases with age and very uncommon, less than 2 years old. So again, the kind of molecular mimicry or the cross-reactivity occurs with the peripheral nerve components or myelin sheath. These kids can present with sensory abnormalities, paresthesias, loss of peripheral sensation in an ascending paralysis form. And then loss of reflexes. These are the key features that distinguish GBS from acute cerebellar ataxia. And as I kind of mentioned, so it's often in lower extremity or symmetric ascending paralysis or weakness. And the predominant symptoms of GBS at presentation in kids are pain and gait difficulty. In preschool aged kids, the most common symptoms are refusal to walk and pain in the legs. And then treatment is typically IVIG or plasmapheresis, and then more than 90% of patients reach the nadir of their function within 2 to 4 weeks, followed by return of function occurring slowly over weeks to months. So these are some toxic ingestions. So your anti-epileptics, lead, carbon monoxide inhalants, alcohol, and benzos. I won't spend too much time on this. And a little bit less common as well, labyrinthitis, so inflammation of the vestibule of the inner ear due to bacterial or viral infections. And these kids can present with hearing loss, vomiting, intense vertigo with head movement, nystagmus, and ataxia as well. And then other common or less common conditions. So tick paralysis is another ascending paralysis after tick bites. Congenital conditions, so your Dandy Walker and Chiari-1 malformations, and then degenerative conditions, so your ataxia, telangiectasias. So this is a rare autosomal recessive disorder with cerebellar atrophy leading to progressive ataxia. These kids also have tons of sinopulmonary infections, telangiectasias, and malignancies. And then conversion disorder can present with a wide range of neurologic presentation, but typically a diagnosis of exclusion, not true ataxia. So these kids would present with a narrow base gait as opposed to a wide base gait, and kind of pseudo type symptoms. Okay, so next question.
A 5-year-old boy with no medical history presents with 3 days of progressive inability to walk. At first, his mother thought he was just tired from a long day at the park, but this morning when she got out of bed, his knees buckled inward and he could not support his weight. He's recently been ill with a low-grade fever and mild diarrhea which are resolving. There's no trauma, headache, vomiting, or leg pain. Despite eating and drinking well, he's not urinated in 15 hours. On physical, his temperature is 37.8, heart rate of 90, respirations 20, blood pressure 156. He's somewhat fussy with normal mental status. Bilateral lower extremities show 2 out of 5 motor strength with absent reflexes but intense sensation. Which of the following etiologies is the most likely cause of the symptoms? Non-polio enterovirus, parainfluenza virus, MRSA, autoimmune, or herpes virus.
Okay, so A, B, C, D, or E. Okay, so the answer is A, so non-polio enterovirus leading to acute flaccid paralysis. So these symptoms are consistent with acute flaccid paralysis, most likely caused by non-polar polioenterovirus. So diagnoses that involve a flaccid paralysis include illnesses like Guillain-Barré, transverse myelitis, West Nile virus, and non-polioenteritis. So autoimmune related myelitis, such as transverse myelitis, may involve bladder or bowel dysfunction, as in this patient, but typically involves sensory deficits also, which is why the answer was not autoimmune. Okay, so we can talk a little bit about myelitis. So acute transverse myelitis and acute flaccid are kind of the most common. So acute flaccid myelitis has been increasingly recognized syndrome in kids, particularly in 2014. We had a few cases in the Midwest area of the US. These kids typically present with rapidly progressive, often asymmetric flaccid weakness. Over 90% of affected kids have a mild viral respiratory illness or fever before the onset of neuro symptoms. Areflexin hyporeflexia is present in the most severely affected limbs, though the reflexes can be normal or brisk below the level of the spinal cord injury. And sensation and bowel and bladder function are typically spared. Although the cause of acute flaccid myelitis is not fully understood, it has a high association with enterovirus infections, often detected in respiratory panels or specimen, but CSF testing is actually almost always negative for enterovirus when tested with PCR. And then based on the current literature, there's no specific targeted therapies or interventions with enough evidence to endorse or discourage their use for treatment or management of AFM, including steroids, IV, IG, and Plex, or plasma exchange, although steroids are frequently utilized and deemed quite effective. So transverse myelitis can result from multiple mechanisms. Idiopathic transverse myelitis refers to a single episode of TM or transverse myelitis, typically from a post-infectious immune activation. Typically the systemic response to enteroviruses, varicella virus, herpes, and listeria. Varicella a little bit less commonly now post-vaccination, but still seen. And then TM can also be part of a relapsing inflammatory disorder, so MS, or neuromyelitis optica spectrum disorder. And those are when you kind of have relapsing or recurrent symptoms. Within the pediatric population, idiopathic myelitis has been more frequently reported in kids under 5 and then over 10 years old. So that 10 to 19-year-old range, kind of most commonly. And then so kind of differentiating transverse myelitis and GBS. So TM or transverse myelitis can be mistaken for peripheral nervous system disorders like GBS. They can both manifest as weakness and areflexia or no reflexes, but a sensory level and urinary retention really should raise your red flag for transverse myelitis or spinal cord localization. And then although not typically, ataxia presents with a rapid onset of motor weakness and sensory deficits and or bowel or bladder dysfunction, as opposed to flaccid myelitis, which only has motor involvement. So that's kind of the way to differentiate it. And then this is just the diagnostic criteria for transverse myelitis, which I kind of reviewed. But it's kind of bilateral, not necessarily symmetric, sensory motor and autonomic spinal cord dysfunction with a clearly defined sensory level, and then progression of the deficits between 4, so basically hours to 3 weeks after symptom onset. And then spinal cord inflammation, and then exclusion of compressive or post-radiation neoplastic or vascular causes. And transverse myelitis typically manifests as abnormal T2 FLAIR hyperintensities on MRI, affecting a long segment of the cord. So greater than 3 to 4 segments or more than 2/3 of the cord, versus shorter segment lesions are more suggestive of kind of an MS picture. And then as far as treatment for acute transverse myelitis, so the American Academy of Neurology guidelines state that steroids only have class 4 evidence to support their use, though in practice they're often first-line treatments, kind of similar to your acute flaccid myelitis. Typically steroids are 30 mg per kg up to 1 gram of IV methylpred daily for 3 to 5 days. And with severe cases of myelitis or symptoms refractory to IV steroids, Plex has also been an effective treatment for acute transverse myelitis, usually in conditions where pathogenic antibody is kind of central to the disease process. And studies of plasma exchange in kids have demonstrated that it's a safe and effective treatment as well. And lastly, so the recovery for transverse myelitis and acute flaccid myelitis. So the motor recovery for acute flaccid myelitis tends to be slower and a little bit less complete, or kind of more residual effects compared to transverse myelitis. So although many kids have substantial recoveries from transverse myelitis, as high as 40% have residual deficits that interfere and impact with their quality of life. So improvement of spinal cord function is typically the most apparent in the first 3 months following the onset of symptoms, but can continue over many years with appropriate rehab. Motor recovery from acute flaccid myelitis is slower, less complete compared to transverse myelitis. And a recent study at Colorado basically showed that the majority of kids with flaccid myelitis exhibited persistent motor deficits at about a year. Questions, Adam?